Welcome back to the deep dive. Today, we're tackling something that feels, I don't know, both incredibly high stakes and surprisingly low tech.
It's a real paradox, isn't it?
Yeah, because we always think of medical breakthroughs as, these giant MRI machines or AI diagnostics. But our sources today, we've got a whole stack of them, resident training guides, ENT protocols, they argue the complete opposite.
They're pretty adamant about it.
Yeah.
The consensus is that in ear, nose, and throat, or ENT, something like 80% of the diagnosis comes before the doctor even touches you.
80%. That is just a staggering number. It means the scan is basically just the confirmation photo.
Exactly. The real detective work, the Sherlock Holmes part,
Yeah.
it all happens in that initial conversation.
So that's our mission for today. We're going to try and reverse engineer that conversation. We're going to look at the detective grid that these ENT specialists use. And it all starts with the part of the form I think we all just skip over.
The patient particulars.
Yeah. Name, age, sex, occupation, the boring stuff.
Except it's not boring at all. I mean, most people see it as just admin fluff, but in this world, those 4 lines, they set the entire stage. It's all about pre-test probability.
Right, and the sources really hammer this home with age. It's not just a number, it's like a biological filter. The example that really stood out to me was a sore throat.
Oh yeah,
If I'm 20 and I have a sore throat, it's annoying. If I'm 70 and I have the exact same symptom, it's a potential crisis.
it's a completely different ballgame. For a young person with dysphagia, that's difficulty swallowing and a sore throat, you're statistically just looking at inflammation. Tonsillitis, maybe a quinsy, it's an infection.
Okay.
But you take a 70-year-old patient, same symptoms, and the probability of infection plummets, and the probability of malignancy of cancer, it just skyrockets.
So just from the birth date, the doctor's mental flowchart has already switched from prescribe antibiotics to maybe schedule a biopsy.
That's what we call the index of suspicion. It changes everything. It changes how you hear the rest of the story. You see the same thing with infants. White patches in a baby's mouth, it's almost certainly going to be oral thrush.
But in a 50-year-old smoker,
That's very likely leukoplakia, which is a precancerous lesion. The context is everything.
okay, so then we have gender. And, beyond the obvious differences, the guides pointed to this one really specific kind of strange correlation. It was about iron deficiency.
Ah, yes. This is a classic medical school pearl. There's a condition called post-cricoid carcinoma. It's a tumor that grows in the hypopharynx, right behind the voice box. And the data is very clear that this is way more common in females.
But not just any females, right? It was linked to anemia.
That's the thing. It's often tied to something called Plummer-Vinson syndrome. It's this triad of dysphagia, iron deficiency, anemia, and these little tissue flaps in the throat called esophageal webs. And for reasons we don't fully get, this whole profile is almost exclusively female.
So a pale woman who says food gets stuck in her throat. That just sets off a completely different alarm bell.
A very, very different alarm. It's like a demographic fingerprint for that cancer.
Okay, what about occupation? I'm guessing this is where we separate the talkers from the breathers.
That's a great way to put it, actually.
Right.
We call them professional voice users. So you're thinking teachers, singers, lawyers, even people who shout at markets.
Talkers, yeah.
If a teacher comes in with a hoarse voice, your first thought is mechanical wear and tear. Vocal nodules, polyps. It's like calluses on their vocal cords.
As opposed to the breathers, the industrial workers.
That history is, well, it's a lot darker. If you see welder or shipbuilding or even woodworking on a chart, your mind immediately goes to inhaled carcinogens. Asbestos, nickel, wood dust.
So a hoarse voice in a welder is probably not a nodule.
It's a huge red flag for laryngeal cancer. The job title tells you what kind of abuse the tissue's been taking for the last 20 or 30 years.
Wow, even geography comes into play. The sources called it the geography of disease. I found this iodine thing fascinating.
It's pure geology affecting biology. In the Himalayan belt, the soil is iodine deficient. Your thyroid needs iodine. If it doesn't get it, it just swells up trying to grab more. That's a goiter.
So a neck lump in someone from the Himalayas is statistically more likely to be a benign goiter than for someone living on the coast.
It just helps you filter out the noise.
Yeah.
If you know the background risks, you spot the weird stuff faster.
All right, let's move from the person to the actual problem, the presenting illness. We have to start with the nose.
The gateway. And honestly, the way doctors analyze nasal discharge rhinorrhea, it's way more involved than just, I need a tissue.
The sources break it down right. Watery purulent, which is that thick pus-like stuff, and blood-stained. But there's this one scenario with clear, watery discharge that is, frankly, terrifying. The CSF leak.
This is one of those aha moments in diagnostics. So patient comes in, they've got a runny nose, it's clear liquid, they think it's allergies. But the good doctor asks a very specific question.
Yeah, which is?
Does it get worse when you bend forward? Like when you tie your shoes?
And if they say yes, it just pours out when I bend over.
Then it's probably not mucus. It's cerebrospinal fluid. CSF.
The fluid that cushions the brain.
The very same. It means there's a tiny hole in the sac around the brain, and it's leaking through the skull into the nose. It's a plumbing leak, basically, from the brain compartment to the nasal one.
And bending over is just gravity doing its work.
Exactly. CSF is thin like water. It flows instantly. Mucus is sticky. It doesn't just gush out like that.
Why is that so dangerous? I mean, apart from the obvious horror of it.
Because if fluid can get out, bacteria can get in. It's a direct highway to the brain for meningitis. If you misdiagnose that as allergies, you could be sending them home with a ticking time bomb.
That one question is literally a lifesaver. The guys also talk about a golden rule for unilateral versus bilateral symptoms, one side versus both.
This is one of the biggest heuristics in all of medicine. Systemic things, like viruses or allergies, they usually happen on both sides. Both nostrils run, both eyes itch. Bilateral is usually medical.
But unilateral, just one side, that's a red flag for something else.
Unilateral means there's a local problem. It's surgical. The classic example is in kids. A parent brings in a child with this foul-smelling green gunk coming from only the left nostril.
I think I know where this is going. There's something stuck up there.
Almost every time. A bead, a piece of a crayon, a bean. The kid shoves it up there, forgets about it, and then starts to rot. That smell is often the first clue.
So a one-sided stinky nose is a sign of a lost toy.
In a child, yes. In an adult, unilateral discharge is a lot more sinister. You worry about tumors, fungal balls. The rule always holds. One side means something is physically, structurally wrong right there.
Let's talk about the sense of smell itself. We've all heard of anosmia losing it completely, but the sources have these other terms, parosmia and cacosmia. They sound almost like hallucinations.
They're distortions, really. Parosmia is like a rewiring error. You smell fresh coffee, but your brain registers it as, I don't know, burning rubber. We saw a ton of this with long COVID as the nerves were regenerating but getting cross-wired.
And cacosmia, the definition was specifically smelling a bad odor.
Right. It's the perception of a foul smell, like rotting meat, that isn't there. But in ENT, it's often linked to a condition called atrophic rhinitis, or ozema.
And this is where it gets really cruel because the patient can't smell how bad they smell, right?
It's the tragedy of it. The nasal lining basically wastes away and forms these huge crusts that are full of bacteria. The smell is horrific to everyone else in the room. They call it merciless. But the patient's own smell receptors are dead. They're completely anosmic to it. They have no idea.
That's awful. Okay, before we leave the nose, nosebleeds, epistaxis. The sources draw a sharp line between nuisance bleeds and dangerous ones.
It's all about location, location, location. Most nosebleeds, especially in kids, are anterior. They're from a spot called Little's area, right at the front. You pick your nose, it gets dry, it bleeds. You pinch it, it stops.
But the bad ones are posterior, Woodruff's area.
Correct. That's way in the back near the throat. These are the bleeds you see in older patients with high blood pressure. The vessel that ruptures is bigger, and because it's so far back, pinching the front of the nose does absolutely nothing.
So the blood just goes down their throat.
Exactly. Sometimes they don't even bleed out the front. They come in coughing up or vomiting blood because they've swallowed so much of it. It's a cardiovascular emergency.
Let's move down to the throat. This is where the detective work felt like it was all about audio clues, the quality of the voice.
The voice is an amazing diagnostic tool if you know how to listen.
The phrase that jumped out at me was the hot potato voice. It sounds funny, but the description is clearly an emergency.
It's a perfect description, actually. Imagine trying to talk with a steaming hot potato in your mouth. You wouldn't open your jaw much. You'd keep your tongue back. The sound you make would be thick, muffled, and strained.
And what's actually causing that sound in a patient?
A massive swelling in the back of the throat, usually a quinsy, which is an abscess next to the tonsil, or even worse, epiglottitis, which is the flap over your windpipe swelling up. The sound is muffled because there's literally no room for the sound to resonate. It's a huge airway risk.
Then you have hoarse versus breathy. I mean, to me, they just sound off, but you're saying they point to totally different problems.
Completely different mechanics. Think about it. A hoarse, or rough voice, means the edges of the vocal cords are irregular. There's a lump, a nodule, a polyp, a tumor, so when they vibrate, it's chaotic.
It's mechanical obstruction.
Right. But breathy means air is escaping. The cords aren't closing all the way. There's a gap, and that usually points to vocal cord paralysis. One of the cords is just stuck, so air just leaks through.
So hoarse is a bump, breathy is paralysis.
As a general rule, yes. It tells you whether you should be looking for a mass or checking the nerves that run down into the chest.
The most Sherlock Holmes level question in the whole thing was about time of day. Is your voice worse in the morning or the evening?
This is such a critical question. It's how you differentiate between reflux and fatigue.
Okay, break that down for me. If I wake up hoarse, but I sound fine by lunch, what's that story?
That is the classic story of laryngopharyngeal reflux, LPR. When you're lying flat all night, stomach acid can creep up your esophagus and pool in your throat, bathing your vocal cords in acid for hours. You wake up with swollen, boggy cords.
But as soon as you're upright.
Gravity takes over, the acid drains away, the swelling goes down, and your voice comes back.
Now flip it. I wake up fine, but by 5 p.m. I can barely speak.
That's vocal fatigue, and that's more concerning. It can be from overuse, like a teacher, but it's also a major red flag for a malignancy. A tumor adds mass and stiffness to a vocal cord. The muscles have to work way harder to make it vibrate. By the end of the day, they're exhausted.
So evening hoarseness is actually a more worrying pattern.
In the context of looking for something serious, yes. It suggests there's a structural load that the body just can't sustain all day.
Let's talk swallowing, dysphagia. The sources laid out this swallowing paradox about solids versus liquids.
Yeah, this trips a lot of people up. You'd think if you can't swallow, you just can't swallow anything.
But the key question is what gets stuck?
Exactly. If a patient says, I can drink a glass of water, no problem, but a piece of bread gets stuck, that's mechanical dysphagia. There's a physical blockage, a tumor, a stricture acting like a dam. Liquid can trickle past, but the solid chunk hits a wall.
Okay, and the reverse. I can eat a sandwich, but water makes me choke and cough.
That points to neurological dysphagia. Swallowing liquid requires incredibly fast, precise nerve coordination to protect the airway. Solids are slower, gravity helps them down.
But liquids are just too fast for a damaged system.
They're fast and unforgiving. If the nerves are damaged from, say, a stroke or some other palsy, you lose that split-second timing. The liquid goes down the wrong pipe, into the lungs or up the nose.
So, solid stuck equals a blockage. Liquid stuck equals a nerve problem.
Precisely. It tells you what kind of scan to order. Are we imaging the pipe, or are we evaluating the wiring?
There was one simple physical test mentioned that I found fascinating. The finger test for trismus.
Trismus is just lockjaw, the inability to open the mouth. And the test is simple. We ask the patient to put their own 3 fingers vertically between their front teeth.
And 3 fingers is normal?
It's about 5 to 7 centimeters. Yeah, that's a normal opening. If they can only fit 1 finger, that's severe.
Yeah.
And in ENT, it's rarely just a stiff jaw joint. It's a red flag for something infiltrating deep into the muscles of chewing.
We have to touch on habits. The sources stress doing the math on smoking. The pack here.
Right, you have to quantify the risk. It isn't a yes-no question. You calculate the dose. It's the number of packs smoked per day multiplied by the number of years they've smoked.
So 1 pack a day for 20 years is 20 pack years.
And 2 packs a day for 10 years is also 20 pack years. That number gives you a direct statistical correlation to their risk of cancer. It turns a habit into hard data.
And then there's referred pain. The sources call this the pain that lies, specifically with ear pain.
This is probably the most dangerous trap in all of head and neck diagnosis.
Yeah.
We call it referred otalgia.
So the patient comes in with terrible ear pain. The doctor looks in the ear.
And it looks perfect. Totally normal eardrum, no infection, no fluid.
And the patient thinks, great news.
But the trained ENT thinks, oh no. Because the nerves that supply sensation to the ear, the glossopharyngeal and vagus nerves, also supply sensation to the back of the throat and the base of the tongue.
The wires are crossed.
The brain gets a pain signal from a nerve and can't tell where it originated. So a tumor growing silently at the base of the tongue sends a pain signal, and the brain registers it as coming from the ear.
So a normal ear with bad pain is basically a giant arrow pointing to the throat.
It forces you to hunt for a hidden cancer in the pharynx or larynx. You never, ever ignore referred otalgia. It is the single most important red flag.
That's a chilling but vital point. Okay, so the sources wrap up with a kind of scary list. The absolute non-negotiable red flags.
These are the do not miss signs. Number 1, hoarseness that lasts for more than 3 weeks.
Why 3 weeks specifically?
Because a simple viral laryngitis should clear up in 2 weeks. If it's still there after 3, it's not a cold anymore. Something is persistently irritating that cord. It needs to be looked at with a scope.
Okay, what's next?
A neck mass, specifically a lump that's bigger than 2 centimeters, feels hard and is fixed.
Fixed, meaning it doesn't move around when you push on it.
Right. Benign things like cysts tend to be mobile. Cancers tend to invade the tissue around them and get tethered down. They feel stuck.
And the last one.
Progressive dysphagia trouble swallowing that's getting steadily worse, especially if it's paired with unintentional weight loss.
Because that means the blockage is growing and they literally can't get enough food down.
Exactly. The body is starving because the machine is broken.
You know, going through all this, it just strikes me how much of it is about translation. The patient says, food gets stuck, And the doctor hears mechanical obstruction.
That is the art of it. The patient is the storyteller. They have the experience. Our job is just to translate that experience into anatomy and physiology.
It really reframes the whole idea of a doctor's visit. The patient isn't passive, they hold all the data.
We tell residents all the time, just listen to your patient. They are telling you the diagnosis. If we stop cutting them off and actually listen to the timing, the quality, the triggers, the scan just ends up confirming what the history already told us.
It's empowering for the patient too, I think, knowing that the details of when and how a symptom happens really matter.
Absolutely. The next time you notice something, pay attention to the context. Does your nose drip when you tie your shoes? Does your voice clear up after your morning coffee? Those aren't just weird quirks. They are diagnostic clues.
And if your ear hurts, but the doctor says your ear is fine.
Make them look at your throat. Please.
Well, on that critical note, I think we'll wrap up this deep dive. This has been a true masterclass in medical detective work.
It's always a pleasure to decode these things with you.
Thanks for listening. We'll catch you on the next deep dive. Stay curious.
Stay curious.